Hi everyone, thank you for joining us for this session. This time we're talking about evidence-based treatment pathways for patients with chronic pain and specifically delivering it via telehealth. So the people we're talking to today are really doing evidence-based treatments that have been independently verified to work delivered via telehealth, which is exciting for all of you, particularly at the moment during COVID-19. We're going to talk about the research behind the sort of current pain science. Sorry, just was hearing myself. So we're going to talk about the research behind the current methods of pain science. Also, we'll talk a little bit about the skills deficit that exists with practitioners out there at the moment, dealing with chronic pain specifically, and how telehealth can even actually benefit this way of helping your patients, because sometimes a hands-off approach can be valuable in this new methodology of pain science. So the last thing I was going to mention is also towards the end of this session, we're going to look up some note templates that are going to be provided to you. This is really exciting. They're such a valuable thing. So the guests we have on today have put together a whole series of treatment notes that can be imported straight into Cliniko, and they're making that available to you. So you can bring them right in and start applying and using the information you learned today immediately. So let me bring in Dave and Jack into the session with me. Hi, Dave. Hi, Jack.
G'day, mate. G'day, mate. G'day, everyone.
Thank you so much for joining us with this session and being prepared to share this information with everyone. Perhaps we could just start maybe with you, Dave, first, a little bit of background, what you've studied and, sort of work life, things like that.
Yeah, sure. So I studied physiotherapy at the University of South Australia and then went back to do a Masters of Musculoskeletal and Sports Physio. While I was doing that, I was working at Body and Mind with Professor Lorimer Mosley, working in pain research. And then I went to Lorimer and I spent about 6 months, drafting a PhD that I was going to do around knowledge implementation. We then just decided that it was a little bit, ironic to research implementation, that we should just do it. So I left there and set up a clinic and have been running projects since. So Tame the Beast and now Permission to Move.
Awesome. And what about yourself, Jack?
Yeah, so I'm a physiotherapist as well. I graduated from the University of Queensland in 2012. I moved down south to southern New South Wales for my grad year and worked in public and private and got pretty interested in persistent pain straight away and got involved in developing a public chronic pain program over there. I moved over to the UK and worked across a bunch of different areas in the NHS in persistent pain as well, and then moved back to beautiful Adelaide here and managed to jag a job with Dave, and I've been really passionate about this stuff ever since. So yeah, I'm really enjoying my time here.
So why do I get the feeling that especially for our people viewing overseas, they're going to learn a whole lot of new phrasing while we go through this chat tonight, like jag a job. I have a feeling we're going to be enlightening them in a bunch of different ways.
Yeah. Be mindful of the accent as we go.
No, it's good. It's educational on all fronts. Just before we get into some of the questions and some of the content we're going to talk about, I'm actually just want to let everyone know that you can make comments in YouTube there. So if you make comments and if you have questions for us, do make them. We will be reading them and I'll be able to ask those questions if you put some forward of the guests during the session. So if there's something that we're talking about that you want to know more about or take it in a slightly different direction, feel free to put your questions in the comments. I also see quite a few people introducing themselves, where they're from. It would be really great if you do want to make a message in there, maybe what country you're in and also what your modality is. Would be interesting for us and help us tailor the session that we're talking about as well. So just coming to what you both are doing work-wise at the moment. So you still have a clinic. You have this clinic that you're seeing patients with. You have done a lot of research on chronic pain, and you have a product and sort of coaching that you do. Maybe if you can just give me a summary of the different parts of your business that you operate now.
Yeah, so the first business I set up was Form Physiotherapy. So that's the clinic that's just out that way. So we're in the studio at the back now. And that started just early 2015, but we moved into this premises around about June 2015, actually. So that there has evolved now. We've got 7 clinicians and a practice manager, mainly working with compensable injuries, so third-party insurance and work injuries. We're probably 30% private list, 70% compensable. It was 2 or 3 years ago we did Tame the Beast with Lorimer, this free education project for pain patients. And then it was about a year after that I started Permission to Move. So this is, now for me, that takes up most of my time. We first wrote a book, I guess summarising the learning that we'd had in a clinical practice model called Permission to Move. And then we spent the last kind of year fairly intensively building that into this online course that's now available for patients, and also a course for clinicians that helps to upskill clinicians in this model. So my role now is mainly developing education resources, whereas Jack, you're probably more on the front line treating.
Delivering the clinical content at a coalface, I think. Yeah. Sure. And so I think the powerful spot that we're in, where we're, developing and implementing clinical tools at the same time, which I think sometimes clinicians can feel like I guess that space is fairly far removed. But I think, we're right there, developing and implementing, which is pretty cool.
Awesome. You mentioned briefly Tame the Beast. So if people haven't seen it, what is that exactly?
Yeah, so Tame the Beast is it's a 5-minute animation that talks about, it helps a novice, a person who doesn't have any prior knowledge of pain, develop an overview skill set in the pain science content that research has been providing. The outcome of the video is 3 questions, or a set of questions to take to your health professional. On the website, we've got podcasts, so stories of patients that have used this sort of an approach. And they've had so they're now up to sort of 1,400, 1,200, 1,400 hits a podcast. But the animation's been, it's embedded in lots of pain programs and hospitals all over the world. So our measure on views is somewhere between 1 and 2 million at the moment, which is, it's had really good uptake as a project. I think for us, it was just always, we felt like that project helped people ask a lot of questions, but there wasn't really anywhere for people to go. So we got a huge amount of email correspondence from patients asking us, like, what do we do next? And we would try and locate patients with clinics in their area, but it's just, and we'll cover this later with this skills deficit, but I think this is just a new area, and we found it hard to locate people, and that was really the motivation to extend it, I guess.
Okay, cool, nice. I just had a glance at the comments to see what sort of modalities that are coming through, so maybe we can, lean this conversation in that direction. And frankly, the people watching are not helpful at all. I think it's like every different modality I've ever heard of are coming up in the chat there. So I think that probably we're covering a wide base here. So, things that are applicable for all will be good. Probably, that's a relevant thing to touch on now, though, is, so the approach we're going to talk about, there's a pain science approach we're going to go through here and how it's delivered via telehealth. But what sort of modalities can do this? What sort of modalities make sense to deliver this that we're going to discuss?
Yeah, I think if you're dealing with people who've had pain, and particularly people who've had pain for an extended period of time, and we'd often say over 12 weeks, then this content is going to be really, really relevant. And so with physios, chiropractors, osteopaths, kind of the classic manual therapists and people in that space who might use this content, but also psychologists, podiatrists, doctors and GPs and specialists, and exercise-specific clinicians as well, like exercise physiologists, trainers or sports trainers, I think in the United States is probably a term that's used a lot, as well as personal trainers, I think.
So last year just briefly, last year we ran PD courses and we had pretty much one of each of those professions in there. We presented to a group of GPs. We did a 3-hour intensive workshop to, I think it was almost 200 psychologists. We and then we had everyone from physio, chiro, osteo, EP, nutrition, dietetics. We've even had a speechy come through, and I think it's so much just around contextualizing recovery, and the skill set's really broadly available.
So here's going to test that idea, because we've also had a couple in here that are animal physiotherapists. Is that going to stretch the boundaries of this approach?
Yeah, look, I had a person who has racehorses come through the clinic talking about tendon rehab, and they were convinced that if we could solve tendon problems in horses, we'd be doing well. But maybe some of the exposure content might. But
definitely.
I think, principles of exposure. Let's workshop that.
Okay, sounds good. So talking about chronic pain, maybe for more my benefit than the practitioners watching, because they're probably already aware, but what would, define someone as chronic pain? So if a practitioner is to look at their existing patient list and say, okay, I'm going to, look at treating chronic pain in a different way, how do they know who has chronic pain? What's the sort of definition for it?
It's such a good question, and I think, that really comes to the center of this whole thing is that is around definition. So the strict one would say is just any pain that's lasted more than 12 weeks. And I think what we're seeing with a lot of our one-to-one and individual mentoring of clinicians is that people don't pick up on chronic pain very well. Lots of people are tempted to think about chronic injury and instead of this sort of transition to some kind of chronic pain biology potentially. So we think really generally around just any pain that's lasted more than 3 months, but it probably even predates that 3-month period, that 12-week period. I think changes that fit with this biology, probably happen immediately after injury, and then it's just a continuum in our mind. Maybe the definition for me more around chronic pain is the pain getting in the way of you doing things that are necessary for recovery. So it's not so much hard deadlines, but I think that's a really neat definition. Yeah.
Sure, that sounds good. I'm interested as well for people that are watch along, if you want to put in the comments, does that match with what your existing perception of chronic pain was? Is that sort of, universally accepted with the knowledge you had, or is it, that kind of 12-week period something new for you? I'd be interested to know as well, because, there's two parts to what we're talking about here. We're talking about this pain science approach, and we're talking about its application via telehealth. So it's interesting to know, I guess, how many people are already looking at this modern pain science approach in their practices. So speaking of, and maybe before we go into the details of what that looks like, is there some evidence behind this? Obviously, every time we have a discussion like this, and I've done some of these broadcasts, what kind of evidence backs the approach to pain, to pain that we're talking about, and then also particularly telehealth as well?
Yeah, I think maybe start broadly with pain science approach to musculoskeletal pain. And sometimes we think about this slightly differently, in the idea that we know that for chronic musculoskeletal issues that there's fantastic evidence for like long-term behavior change and exercise-based treatments. And so I think it's really helpful to look at pain science as a way of developing that in your patients. So a way of developing like sustainable, healthy movement and healthy behavior change. And so pain science is almost an avenue to get that.
A lot of researchers looked at just doing pain education on its own, and I think it's another important difference about how we're approaching this is that we're really using the education as a gateway to behaviour change instead of looking for an effect from just pain education itself. So for us, I think maybe 5 years ago we were just talking pain education, but now it's sort of pain biology education, tissue healing education, self-management advice, and just this kind of culture of recovery and training self-management. So all of those principles around increasing exercise, recovery, self-efficacy, these long-term behaviour skill sets or behavioural change and new skill sets, they've got fantastic evidence. There is Explain Pain from Noi is probably the best book to summarise the evidence, and then their new book, The Supercharger, they go into the details there. There's certainly evidence around this, but I think we as a group look at it more as the way we've just described. Yeah,
a really good specific example is something like knee osteoarthritis, where the research is really clear that behaviour change and physical activity are top-line treatments for knee osteoarthritis, which some people will be really surprised by that. And then we see like pain science as an avenue for someone who's really certain that exercising on their damaged knee is going to be catastrophic for their recovery, that we can turn that into a positive and a way for them to move forward through recovery.
Now, those two books that you mentioned, who was the author of it? Because we'll get some links to that we provide to everyone afterwards.
Oh, yeah, great. So the authors are Dave Butler and Lorimer Mosley. The first book's probably more clinician-facing. It's called Explain Pain, and the other book's called Explain Pain Supercharged, and that's more directed at clinicians. So that goes through a about developing an educational curriculum for your patients.
Okay, great. And it's probably worth mentioning as well, at the end of this session or soon after this session, we will send out an email to everyone that registered that'll have links to any of the key things that we talk about during it, and also those treatment note templates that I mentioned at the start. Everyone will get an email. We'll also update this YouTube video in the comments with those links soon after the session as well. So that's evidence for the approach. Then what about the telehealth part of it? Because it feels a lot like, there's been a mad rush to telehealth very recently, but obviously, telehealth was around before that. Is there evidence for delivering this via telehealth?
Yeah, we've been in the telehealth game for, what would you say now, Dave? I think a good few years. Most recently, we've been conducting
we recently did a clinical feasibility study with Body and Mind. So Laura Mosley's pain research group, we put forward this coaching plan, and actually just as a link, the coaching plan that's in our session notes for the Cliniko notes that you'll download is almost the exact copy of what we delivered in this clinical feasibility study. So that went out to, the intention was 100 sample with a control group at the start, but it ended up going to, I think we finally had 37 participants and 37 in the control group. And so we've got evidence, I guess, from our clinic that a specific process like this works. Our effect size data from that was 0.5 for pain and 0.7 on a retest of an Arebro short form, just a questionnaire. We had a 2.2 effect size on increasing a patient-specific functional scale, but that was also the intervention. So we would say, look at that with caution. That number's probably not reflective. So I guess from our specific clinic, we've developed, been involved in this. But I guess I'm just getting a citation. So a journal. We were just looking before at research around like telehealth for depression, anxiety, and there's so much there. So we've got a bunch of articles, and maybe we can link them to you later as well, but lots of sort of really well designed 800 sort of plus sample in the depression mental health space. And for us, we're delivering a skill set, and we've found certainly in our clinic that doing that through this kind of video chat feature or telehealth works really, really well. Yeah.
Awesome. So in your clinic, when you're delivering this service, this way of treating or helping the patients, what sort of percentage, like I guess, Jack, you said you're still, you're out there delivering probably more so at the moment. What sort of percentage are you doing telehealth versus normal at the moment during, COVID-19?
Yeah, I reckon I'm probably 70 or maybe even 80% telehealth right now, I think. Pre-COVID, it was probably even still 25% or something like that. So yeah, even in the lead into COVID, we were still doing a fair bit of this stuff. But yeah, certainly now I'd say it's well and truly up around that mark. And I think we found it has been, really, really well received on the whole. And I think that's not surprising to us now, having done it for a while. But certainly when we first got rolling, we were, I guess, unsure about how that would go. And a lot of those early chats we did were purely on the phone without even video. And they went just so much better than we expected. We were able to connect with patients and find some really positive outcomes.
We just found that, so like Jack said, what was called Recovery Coach, our clinical feasibility study, that was on the phone. Shifting to laptop, like video chat, little details like for us, we just all got AirPods because we realized that we were just yelling at the computer and it was just not really working in the clinic. So I think we had teething problems like everyone, but now we've just got like the basics down. Our gym space is just lots of squat racks. So we can consult with the patient in a room, and then if we want to do an exercise, go out to a squat rack. But even that, most patients can't go to the gym at the moment. So we're just like more interested in what's behind their camera and utilizing the stuff in their house for exercise. And I guess in that way, it's probably forced us to be better in some ways.
For sure.
Yeah.
Talk about that kind of skills gap, and I think we're leading into it right there, is that those communication and exercise prescription skills, they level up really fast when you have to do it, and telehealth almost forces your hand with that, and you've really got to absolutely nail those fundamental skills.
Yeah. What sort of injuries or chronic pain incidents, I guess, are you seeing often? What are the sort of things that you're treating in your clinic?
We see a lot of backs. I think we probably early on pitched as like a chronic pain clinic, and that in a lot of mindsets is back injuries. But I don't know. It's probably an even mix now between backs, shoulders,
necks and knees.
Yeah. But the 30% that we do see, I used to work a lot in elite cycling. Jack is a very fast runner and seems to get really has a strong network. And Toby, actually, our clinicians are runners. So the 30% that's not compensable are a pretty strong sports list. And we get all of those sports injuries, which for us as well, looking at those through a chronic pain lens, like I think sometimes you think, sporting injury, they wouldn't have chronic pain. But when we started to look at these things differently, you just you can see patterns everywhere, approach things differently, and get really interesting results.
So maybe the takeaway for people watching then is, in helping their businesses through this COVID-19 time, telehealth and chronic pain treatment is certainly something that they can do through this period, but also they should become runners, because that gets you around people that could become patients of yours in future. So if you're not running now, you should get out there and start running is the key thing.
Plenty of people out there running at the moment.
Or just, it seems any activity that could cause injuries with people, it's a good thing to be a part of them. Is that? Cool. I have a question about fibromyalgia, if that's something that would be applicable for this approach.
That's spot on. Yeah, in our early kind of scoping to see online who would be interested in this. Fibromyalgia as a cohort, people with fibromyalgia are really interested in this content, and through the clinic we see lots of patients with fibromyalgia. Definitely. So I would say that fibro would be more or less a perfect fit.
Sure. For this and another question came up, I know we touched on it briefly, but asking about for psychologists as well, that this would be an appropriate thing for them.
Yeah, in the book Permission to Move, we work with a psychologist, John Baranoff. He's a researcher, that's his postdoc researcher plus psychologist. He works with the Australian Institute of Sport and AFL. He's we think John is great. He worked with us on the book, and he actually, I mentioned earlier, the 6 months of planning a PhD with Lorimer. John was going to be the other supervisor on that. So this approach has been informed at a really deep level by psychology, especially self-efficacy theory. And I've always tested the ideas that we've had around John, and we've actually workshopped a communication tool so that psychologists and physios can, that was what the intended use was, but it could work for any clinician group actually, just to communicate what they're doing so that we don't have dual goal setting in teams that are co-treating. But yeah, this approach for psychology, it's a great fit. They probably just need a clinician to work with who can answer the question, is this patient safe to move? And then communicate that back to the psychologist, and they're ready to go. So
outsourcing some of the diagnostics somewhere.
Excellent. So let's talk a bit about the actual approach itself, get into the details. So there's quite a few people in the comments I saw are familiar with the modern pain science approach, but I'm sure not everyone. If we're kind of to summarize it as an overview, what are the key parts that are different to what they might be already doing? So I know in our chats before, you talked about there's some evidence out there that suggests that maybe 80% of patients aren't receiving a modern pain science approach to their chronic pain. Is that right?
Yeah. So that's from a really large company in the US that also do research in this space. But through the Deloitte Access Economics did the cost of pain report, which is very much worth a read. It's that was helped through Pain Australia. That said that 1 in 100 people with chronic pain in Australia get multidisciplinary care, and multi-D care is recommended for chronic pain. So in a way, you might even say that 99% of people don't get best practice care, but that's probably a stretch. But this idea that at the moment, well, that is a stretch, but just this idea that at the moment there's just lots of systemic stuff that's not really set up to treat chronic pain. We look at, Medicare schedule in Australia is really tricky. So I think different point, but the model essentially maybe I'll go through our model, which is 3 steps. The first step is to establish if the patient is safe to move, and then that has this idea that we call a constructive diagnosis. And this idea is essentially, if you look at tissue imaging findings in people that don't have pain and compare that to a population that do have pain, in a vast number of problems, there's no statistical difference between those data sets, or not. It doesn't reach significance. So the point being that in chronic pain, diagnosing a pathoanatomical or a tissue diagnosis is, if you're doing it with scans or if you're doing it with where it hurts, that's a flawed system to arrive at a diagnosis, because there are so many other reasons that a person could have those scan findings, and also reasons that they could have that pain. So I guess what we're starting to learn is that diagnosis is just really tricky, and maybe clinicians feel a pressure to label something, but actually the science says if you label it, you're just as likely to get it wrong as you are to get it right. And if you get it wrong, you've just given someone a sentence that they're now stuck to. You've said they've got a disc bulge, so they might not want to bend forward. So the first step for us is establish safe to move, generate this constructive diagnosis, which is for us saying you're safe to move, plus or minus some caveats that you might add through your clinical reasoning until you get more information. And we're going to monitor your response to this through watchful waiting to make sure that diagnosis is right.
So with the checking if they're safe to move, would potential diagnostics like a scan or something be a part of finding out if they're safe to move?
Yeah, absolutely. Depending on the individual patient situation, I think. And that's where we're certainly not giving this absolute blueprint, but that's where clinical skills come in, you know? And
so is it, yeah, so instead of like coming up with getting a scan to try and put a label on it and say this is what you have, your approach is more get a scan, gather the information to work out if they're safe to move, and that's really the goal you're getting to?
Yeah, Emma Karen, a researcher at Body and Mind, put forward this project called Goleta. It's an acronym that basically means green light intervention to enable recovery or something like that. Her idea is that you should, instead of telling someone the contents of their scan report, just say green light, good to go, orange light, more information required, red light, you've got a fracture, or sorry, it's cancer. Like, yep. I worked with a journo to write the book, and her summary of it was like, if the pain persists, ignore it. And I was like, let's just say if the pain persists, make sure it's not cancer, then ignore it. But like, it's this idea of rule out the really bad things, and if someone's already getting around mobilizing and exercise is unlikely to be dangerous for them, you can have some caveats around this, but just it's this ambiguous space that we're forced to be in because diagnosis is not as simple as it seems. And that's really tricky for all clinicians to work with. But that's sort of the first step of the model, is generating that kind of a constructive diagnosis.
Okay, it makes sense. Just a quick comment or quick mention for people that are commenting. We've got quite a few questions coming through already. So I'm scanning over them, and if they look like something that fits into where we're at now, we'll do them right away. Otherwise, I'll fit them in a little bit later on, because I know what we've got coming, and some of those questions might be better suited to that. But keep the questions coming through for us so we can go through them all at some point through this session. Sorry about that. So you're talking about the first part is, are they safe to move? Which was discussed.
Yep.
And then
sorry. So the second part is communicate that to them, and communication doesn't mean telling them lots of things. It means like, what do they understand? It's the outcome of whatever you do to them, not the process. And I think for us as novice pain educators, that was so important, because you think, I've got to tick off all these key concepts, and we coined a phrase, a minimum effective dose of education. So we give just enough education to enable someone to try a task. Then when they try the task, that's where they get the learning. So you go, Dan.
And we consider kind of education as not just being, delivery of like a book or verbal. We love this idea of experience as being education.
Yeah.
And that's something, and even through telehealth, we're finding that's something that we can do, where we can set up movement experiments with patients that reflect back to a concept that we're trying to illustrate, which might be that that you're safe to move, or that your body's anti-fragile, which is a term that we which is kind of reflects that our bodies get stronger with load rather than breaking down. So we find that that learning and is much more than just throwing content at your patient.
Yeah, so just really briefly, this is where we bolt in the psychology work around self-efficacy theory. So I think that was designed by Bandura to overcome phobias. We've retrofitted it to pain. It basically says, like, the first step, verbal persuasion, explain the ideas to them. Second step, vicarious experience, or give stories of others like them who did the same process and recovered. And then the third thing is mastery experience. And I guess our summary statement here is we funnel people really quickly to mastery experience because we've seen it's far more powerful. Yeah.
That makes a lot of sense. Now, someone just wanted, again, a definition, if we can do it one more time, of the green light, orange light, red light description that you had before.
So that's definitely not my work. And I've spoken to Emma about it. So I'm jumping like the gun a little bit. But essentially, I understood the intention of the study as green light means patient is safe to move, orange light means more information required, and red light means not safe to move. But how
does that marry with the approach you did then? Because you're saying that was someone else's. So what about for yourself? So let's say you get a scan back. You're in that process of seeing if they're safe to move. You get a scan back. What sort of information are you feeding back to your patients at that point?
Yeah, information about healing times we find is really, really important for patients to hear. This idea that our body is just such a great healer and that almost can't stop healing. And that most things, and this always comes with caveats depending on the individual, most things have healed really well by 12 weeks. And that if at that point pain has persisted, that doesn't necessarily indicate that movement is off the table. And that's a pretty powerful concept for a lot of patients. And it opens up kind of avenues to movement and to activities that the patients thought were inappropriate pretty quickly.
Okay. So that's your 2 steps. And then what have you got next? What's the next stage?
Establish, communicate, and then act on. So the act on thing, this is sort of the mastery experience they got in the communicate step is a single rep, I guess, but they will resort back to what kind of, I guess, their prior or all the way that the kind of collective information they had beforehand. They're likely to go back to that, and so we think that, or else kind of assimilate that new learning in a way that isn't consistent with what we intended. So we then need to do reps on that. And in the act-on phase, there's sort of 2 goals. One is if they've had chronic pain for a long time, they may have avoided exercise and they may be very deconditioned. So we might need to create a strength training like improvement, conditioning effect, but we also separate the goals so that we clearly look at using exercise as a sensory retraining tool as well. So if, and this comes to the classical conditioning ideas around pain really, and I think of, say you've got like lifting the gardening pots, putting on your shoes and sitting in the car, well, we need to take each of those tasks that may have been classically conditioned to evoke a pain response and just extinguish each of those through exposure. So there's sort of, in the act-on phase, we're trying to, in my mind, extinguish classically conditioned responses through exposure and also, if required, get a training effect. But this is contrasted against you have pain because body part X is weak and we need to make it stronger. So it's an important little difference, I think, yeah.
So when people are going through this program, typically how does it look at structure as far as sessions? You know, if someone's had pain for many years and, you know, you get them in this program, how quick do they get through these 3 steps? Is this like 6 months? Is it, you know, how does that look? How does it work?
Yeah, absolutely. The process is, I mean, the cop-out answer here, hey, is that it's individual for every patient. But we find that we're certainly not saying that, you know, at the end of, we usually do this as a 6-week program or 6-session program, and we certainly don't say that at the end of this your pain will be gone. But we say that we want you to build a skill set through this 6-week process that you can then carry forward towards recovery, so that you feel like you've got what you need to go on a journey, and that journey ends up with you being far more capable than you expected and that you thought was possible.
So,
and your role might continue after that. You still may have sessions. It might be like start with a fortnight and then go to monthly, and it just really depends on where the patient wants to go and how well they're grasping the knowledge and how strong their self-efficacy is, and but at that stage, yeah, it's really about setting goals, being like external accountability, giving skill sets to achieve the goals, and the role shifts at that stage.
So that 6-week program that you ordinarily do, and like you said, can be different to everyone. So the idea is not necessarily get you pain-free in 6 weeks, but more so empower you to be able to work on getting pain-free long-term. Is that a fair summary?
It's at the end of the 6 weeks, we hope that you have a skill set for recovery. And the stories are absolute, like, so with some people literally have a mastery experience that's really revelatory, and their pain stops and it doesn't come back. Very few people will do that, but the fact that that can happen is incredible in itself. Yep. Most people by the end of, say, 6 weeks feel like their pain's reducing. In our study, it was effect size 0.5, which worked out to, I think, 23% in 6 weeks, reduction on a visual analog scale. So not massive, say like 1.5 to 2 points in 10, but they've got this skill set and all of that qualitative feedback, and the function scale that was a 2.2 effect size. So function went up to a 7.
So when you say visual analog scale, what are you referring to there?
Just a marking on a line that, depending on where you mark it, it's like a score out of 10. Yeah.
Classic pain score, 0 to 10.
Okay.
10's the worst.
It was a question that came up. So you do a 0 to 10 score for sort of pain scale.
Yeah. In the study, there were a few data sets. So it looked at worst pain, average pain, current pain, I think.
Yeah.
Yeah, they were the measures. So, and then I think it came down to an average of those.
Okay. So that's the 6-week period. Then after the 6 weeks, so maybe if we can just look at, in your clinic and when you're seeing people, and maybe again, Jack, if you can think in mind anonymously of some recent people you've been working with. So you do the 6-week session, and then are you still seeing these people? Do you see them weekly, monthly? For how long afterwards? How does that look usually?
Absolutely. So part of the last week is for the patient to almost look at their situation, look at the skills they've developed, and reflect on how much support they feel they need. And then we might set some goals for a period. We might say, righto, let's catch up in a month, and let's look at how well you've gone at achieving those goals and how well those messages and concepts are being retained. And then we might use that to track where we should go with the next one. So if we feel that that's really dropped off, we might say, righto, let's get back in and do a couple of sessions a little bit more frequently and see if we stick a bit more this time, and then go from there. So I think our role is definitely to try and make ourselves, redundant over time, but to really be certain that the patient has the skill set, not for the short term, but for the long game, because we know that long-term behaviour change is what we need.
How do you go for patients that are skeptical of doing this via telehealth? So a patient that thinks that they need to come in for you to put your hands on them and work your magic in order for them to get some benefit or result. How do you convince these people, what's worked for you to transition people to telehealth, or even bring people onto telehealth from the starting point?
That's really, this is a conversation point that comes up in lots of the courses that we've run, is people not feeling as though their patients are going to kind of get it, I guess. And we do an annual survey. I'm just looking for the data, because I think, here it is. Yeah. So this is our annual survey data from 2019. And so 13% of our clients expected to get pain education before they came. So really not many people. 84% of our clients said that they received pain education at the clinic. They identified as getting it. And 82% of people said that this was a key part of their recovery. I guess, and then the net promoter score, which we learned about last year as well, was at 92. So we've got happy clients that don't expect what they're getting, and they say it was a key part of their recovery. So for us, they're really neat proof points that yeah, I think it works.
So if
was the question
that would be okay if someone comes into your, let's say someone's skeptical of telehealth, they come into the clinic and then you transition them to telehealth and they believe in what you're saying and you sort of win them over. But what about a clinic now that needs to do telehealth? They don't have their doors open at the moment and they need to somehow get some confidence either in their existing patient base or potential new clients to say, hey, telehealth actually can work in helping you with your chronic pain even though I don't touch you.
For us, and it's going to sound like a self-plug because it is, but it's actually also why we built it. The online pain program that we've built for patients really addresses that well because it's like really high quality. Our patients go there, they can see immediately that there's a really clear pathway. We induct them into that, and for us, the patients that went through the clinical trial, they knew that they were going to get this. They knew that was coming. Whereas for an average patient in our clinic, they don't know that. So I think for us, having digital tools and a really clear process, just so they get what before the sales moment comes, they know what to expect.
Yep.
So for us, the digital products are great. Yeah,
and we talked about evidence for telehealth-based pain science treatments. Is that readily available that people can look it up and maybe refer to it on their own websites or link to it, or in some way? Is there things that maybe we can provide a link to later that they can sort of back up some claims with?
We did. We got a whole bunch of research ready today, and we'll just send you some links to that. It's, as I was saying before, it's mainly around mental health and psychology. And the paper that we were researched with our methodology isn't out for probably another 3 to 6 months. These things go really slowly, but I think it's a fair call to translate data from the psych space into the pain space, and we'll do a bit more as well and dig a bit deeper into the telehealth for pain specifically.
Probably a good time to remind people, because I see the time and I know we're going to run longer than our hour that we try to keep these to, because we've got some really interesting and important things to talk about still. So for anyone that is watching live now, just a reminder, you'll be able to come back and watch a replay of this later. We'll also be sending out a link to that in case you do need to go. And also because of the timing, maybe some of the questions, we'll keep some Q&A if it's not directly related to what we're talking about right till the end, so that people could leave if they need to and catch up on Q&A later or something like that. But I do expect we've got a little while to go still. So we talked about the basic overview of it, how you're applying it in your clinic, a number of sessions we've gone through. So I thought probably to put something a little bit more practical and tangible, I made mention earlier that we've got some treatment note templates supplied to you to assist you in implementing this into your clinic. Not only do you get these treatment notes, but you're getting them in exported Cliniko files, so you can import them straight into your Cliniko. You don't even need to re-enter them in. I might just bring those up on the screen now, and then perhaps we can talk through a little bit of what we have there. So they should be up now. So what I'm looking at here is I've just got a list of treatment note templates in Cliniko at the moment. And we can see here we've got week 0 through to week 6, and then a 6+ option there as well. So these are just the files that you kindly sent through to me and will be available to everyone afterwards. Import them into your Cliniko. I'll jump into week 0 of these files, of these templates. And what I've got right at the start when I go into here is a how-to guide in the beginning with a fair bit of information. Perhaps you could just talk through briefly what that how-to part is.
Yeah, sure. So the idea there is that once you've read it, you can delete it as well, because otherwise it'll sit at the top of the notes. So just remember to do that. But I guess it just goes through, that there's a base level of presumed knowledge, and that where possible, we've used really deliberate terms that are Googleable. So you can, if you come across something, and our example here is like anti-fragile, you're like, hang on, what is that? Well, that's based on Nicholas Taleb's book of the same name, and you can just Google that. And interesting guy too, like risk management professor, well worth the read. So we try to put out to all of these things. We mentioned the training program that we offer and the resources that we've built to support this, and it's got a little bit of context. So for the plan that we follow through all of them is like, last session you did this. The outcome is going to be this, the outcome of the session is this, and the process to achieve that outcome is this. So we try to stick to a really consistent format. The first session is, we call it actually, week 0, because your patient's not yet in the course. It's how to sort of take your patient and induct them into this approach. So it probably answers the details of some of those questions from before. Like, I guess, all good clinical practice, we start off with building rapport and understanding the story as they see it. It's hard to offer something before the person feels really well understood. So we start with that. We've got content in there on that. And then, we just sort of work through baseline testing, starting to gradually relate their pain story to, like if there's opportunities there to use little illustrative examples from their history and relate it to ideas we start. But nothing significant in this year. We do baseline testing, and then just, where possible, start introducing people to this concept of the way you understand pain is important, and why this kind of an approach is relevant. So we've got content in there around that kind of sales pitch and how to get your patient on board.
I've got an interesting question coming through. Just if you're seeing someone, we talked earlier at the start about what determines defines chronic pain, and we're talking, maybe roughly speaking, it's greater than 12 weeks of pain. How do you go about talking to a patient about it that hasn't in their own mind considered it to be a chronic pain? So as far as they're concerned, they've got a bit of an injury, they've got something, and maybe, using the word chronic pain could have a negative effect or make them start to worry this is something they keep forever. And then, if you're going to try and enlist them into this program and say, look, this pain that you're actually having is chronic, and we should tackle it differently and go into a 6-week program and all this kind of thing. Have you had that experience, and how do you communicate that with the patient?
I'll hand over to Jack in a sec, but it's just sort of, we don't really make a distinction between chronic pain and acute pain. I think probably that's what you'd say.
Something pretty similar.
If it hurts, it's pain. The biology is the same, and we do try to sort of pull away from that strict definition, but I know what you mean about the stigma. I presented to some GPs recently, and one was like, chronic pain, you can't treat that. That's why they call it chronic. And there is a lot of stigma around it. But at the same time, people are getting really excited about treating it. So I think it's changing. But what are your thoughts, Jack?
I think that narrative discussion we have early on, there's some key questions that we include in that patient story. I think often that'll flesh out a discussion point where we'll be able to see this pattern of, repeated attempts at trying to fix this problem that have been unsuccessful. And that can often just trigger a conversation about, okay, maybe it's useful to approach this from a different angle and consider a different approach to this problem. And that starts to just open up doors for conversation.
Yeah, so I'm just thinking, the tangible, you've got a patient you've already been seeing, so they turn up for their next session, and you've been thinking, before they turn up that, maybe this one's an approach I should do differently. So you just start to have a chat to them and say, like, hey, this has been happening for a while. I was thinking of trying a different angle, a different tactic, and then go back to week 0 again for someone they've already been seeing for some time.
Do you want to go?
Yeah, I think definitely we went through this, and sometimes we had that feeling that maybe that's a little bit slow, to start back right there. But these problems have typically been around for a really long time. And I think sometimes the problem with pain science delivery is that we feel like we just have to, quickly rush through it and get to the other stuff, So I think this idea of taking time and listening to your patient and how they digest the content and how they can see it applying to their story is so important. So just like being comfortable staying in there for a little while, I think is super powerful.
Is it an awkward backtrack? Like, is it? I don't know. Is it almost like saying, "Look, I haven't been treating you correctly so far. We're gonna start afresh with this."
Yeah, I think there's just I think it will be slightly difficult to train. Like, we gamed this out as well. I think transitioning someone who's had a long-term treatment approach in a different paradigm will be there's no really easy way to do that. I think for us, whether it's a sports patient or an acute or a chronic patient, that we sort of treat them the same way. But it's not impossible. It's just it's just a little bit of a sensitive, a difficult one. But for us, it would be saying the treatments that we've been doing have been around trying to get your body moving differently again, and they've been we've been giving these movements to your body, but it hasn't triggered the response we want, and maybe there's these other characteristics in your pain story that we can address. But don't worry, this is how pain works for all people, and it's not commonly understood. So if you haven't heard about it, don't feel silly. Most people haven't. Like, just normalizing it and making it a real positive, saying, well, hey, this is thinking differently about your pain now. It hasn't gotten better. And like, if what we've done hasn't given you the results, this is a really exciting new approach, and it gives a new hope for recovery. So there's a way there. It just is a little bit of a balancing act, I think. But we're confident that you can do it.
I think telehealth is actually a great opportunity to have that conversation because, as you said before, Joel, there's an actual physical barrier here for some of the typical treatments to be going forward. So it's a great opportunity if you felt like some of these concepts would be great for a patient, but you've not been sure how to do it. Like, this is just a prime opportunity to doing that.
No,
and sorry, you go.
There you go. Continue.
Just out of the courses that we've done, like, we know, and through the Pain Revolution, a really big social outreach project in Australia, big clinical data set or clinician data set, like, we just know that clinicians have low self-efficacy in this. So our course participants feel like they're going to have conflict with a patient's existing ideas, and so we present data to say it can be done. It can definitely be done. We know it can be done, but your job, like in our method, is to improve client self-efficacy, but actually you need to workshop, if this is new to you, your own self-efficacy and delivering it too. And I think it's just maybe not expecting to be able to pivot fully to this approach day one. Yeah. And that's where a structured learning program is really helpful to say, because I think that's the other feedback we've had, is the ideas are like, great, I get it, but I don't know how it fits in. And we've heard stories of for anywhere from literally just giving someone a book to doing really comprehensive programs. And it's somewhere you'll find a sort of a spot in there that works for you, but it's about questioning those underlying assumptions of your treatment in context of this pain science knowledge. Yeah,
that makes sense. So one more practical application. So you're seeing a new patient for the first time. Do you have a different template that is your normal initial consultation, and then as they start to tell you, I've had this for 4 months now, you switch across to this, or do you always open this template for the first session? How do you, again, just thinking you might not even know until you've started some note taking whether this is going to be applicable to them or not?
The first half of week 0 that's what we do with every patient, really. Getting that pain story and getting a feel for where their story has taken them, sure. whether that's a marathon runner who's come in, or whether that's someone with 20 years of back pain.
Yep. So your process will be, the one I've got up now is this week 0, and I've just scrolled down to the start of the session plan. Also, I've made it a little bit bigger, so it's easier for people to read. But in YouTube as well, you can set your settings to 1080p for the video quality, and if you make it full screen, it'll be easier to see the information on the screen. So you're saying you would open up this particular treatment note template for all and work through it, and then maybe you pivot, halfway or more through, depends on the needs of the person. But the start of this should be helpful to you for any initial consultation.
Yeah, and if you're looking for it, because usually this makes up probably a quarter of your note template, but at the very bottom is patient identity is what we've called it, but it's just all the data around your patient. That's where your objective data can go, and you can populate that sort of with free text. But and then it's at the top of your previous notes, so you can see all of that data really quickly. It seems to be pretty quick.
Sure. I'm just scrolling down to the patient identity section. So that's right at the bottom there. People are watching can see as well the immense amount of work, no doubt, that has gone into building these templates, I assume, over quite some time. Not the template specifically, but the content that goes behind it is quite significant.
Pretty exciting for us. Hey, I was showing our team some screenshots from 2012 where I very optimistically said hey, we got this thing coming, it's going to be ready really soon, and it's not 20 but anyway, it's just good to see we've stuck at this a really long time, and at the moment we're in such a strong position. We just feel like we've finally got content that's really valuable, and our overline top line sort of statement for practice for us at the moment is just radical transparency, just trying to share our insights. We've been so lucky to have a really good collection of researchers and thinkers around us, and we just want to share that while coming up with a platform where we can sort of do it long term. So I guess that's our goal.
Sure.
Yeah.
So talking about delivering this via telehealth, so if you're doing telehealth from the start of this, so that first session is where you would really be opening up this week 0 part of it. Do you send out anything for them to do in advance, or is it a case of, you get started, they book in the first session, you open up the week 0 template, you jump on the call with them and start to work through the questions of it with them?
Yeah, that's it. I'm sure there's lots more that we could do pre-game as well. But yeah, our sort of, we don't do anything beforehand, and that's I'm sure there's opportunity for improvement there. But we always keep busy with other stuff.
I mean, the patient course has a link for patients to fill out a lot of really good outcome data. So that's a really useful tool as well. So
yeah.
So that's something that we will touch on a little bit later, but just so the people are aware, because they're asking also about the telehealth part of it, is that there is a service that they offer, a product they have that allows patients to sort of get, sign in and go through the journey and some online material and work that they do aside from the sessions they have with you. That's a paid product that they have, which we'll show you a little bit later on and talk about, and you'll be able to see on that. Another thing, it looks like really it's a sticking point for people embracing telehealth. Is there anything that you do in the sessions once you've got someone into a session to kind of reassure them that the telehealth can have the result they want?
I think actually as well, I'm just trying to, because we don't get much friction, I'm trying to understand why. Our practice manager is fully around this as well. And I think having he answers questions really, really well and couldn't be more passionate about it. So that's
Tommy's helping us a bit.
I think Tommy's helping us a lot. Yeah. And then in the session 0, we just don't. Yeah, so I think good practice management. They get online. We haven't discounted our telehealth at all. We run 1 hour initials for $145 and follow-ups at 45 minutes at that hourly rate. So I think we're fairly middle of the road priced, but we also haven't reduced our price for this. But maybe it's also the network of people bringing them in. I'm sure it would be different, but
I think that clinician self-efficacy, we really familiar with the content. We're really passionate about it, and we convey that pretty confidently to the patient,
sure.
and I think that really helps. That's what Dave touched on before, developing that self-efficacy around it.
So if I want to summarise the sort of weeks of notes we have here, week 0 is getting them to describe their pain, starting the conversation, getting information and building up a summary of where they're at currently. And then we've got one here, week 1, called Why Understanding Pain Matters. So you can see people are keen to get a little bit of an overview of what each session looks like. So if we were to do a brief overview of the week 1, Why Understanding Pain Matters, what are we doing with the person here? Is it going through again these questions and asking them the questions from the prompts in this template here and recording the answers? And is there exercises happening at this point? How does that session look?
So in this course, exercise doesn't come in until week 5. So for week 1, for each week we start after week 0. Every week starts with what we call standard questions and then zooming in questions. And standard questions are really about, well, what do you remember from last week and how have you applied that? We find that having this is just so important because you're providing education. So without an assessment of your education, you just have no idea where you're at. So yeah, we start every session after 0 with that. And then in the first session, week 0, we went through canvassing why understanding pain matters a little bit. We checked what they understood, and then we really dive into this deeply in week 1, in week 1. And then the helping them to just, because it's such a different approach, we spend a lot of time here and reflecting on their experience, trying to join the dots for them so they can start seeing how the content relates. And then in week 2, we dive really deeply into pain science. So we only have 1 week of the course that's pain science specific. In week 2, that's that. Again, we start standard questions. We zoom into content from the previous week, and then we go through the pain science content. Week 3 is about movement, about the rates of tissue healing and the benefits of movement. So I guess it goes like science of pain, science of movement. And again, start with what do you remember about the pain session, and then specifics, teach them about the movement and benefits of kind of movement, anti-fragile, In the following session, then we go through the diagnostics. So this is establish if they're safe to move. And if you're a clinician who doesn't diagnose, then we've got, it's not in the template actually, but we could provide that easily. It's a really simple red flag screening tool and questions to take to your doctor. So if you're a health professional that doesn't diagnose, then they go out, do that, come back, and your session's around saying, well, what does that mean for you? Let's get this diagnosis alive and start applying it. The next week, we design a movement program with them, and we start doing the first mastery experience. So that's in week 5. And then in the final week, in week 6, we go through the idea of this kind of culture of recovery, which is around having this skill set, a bit more vicarious experience, and goal setting around process versus outcome goals, and just developing a longer term plan, I guess. So that's it in a nutshell.
Okay, that's fantastic. So just touching back, so the first 4 weeks is really education and discussion and not prescribing exercises, not even necessarily asking them to move or getting them moving. Is that right?
Yeah, not necessarily formally, but often we'll find that patients will start to self-generate some ideas around that. And they may well have already come into your clinic doing an exercise program, or I mean, everyone's moving, aren't they? So they may well start to link those dots themselves. So if they do that, we certainly don't discourage it. We'll accelerate patients through that. And the clinician course has more details about how to go about it specifically. But yeah, we certainly wouldn't hold that back. But we find that content is so new and so different that it really takes a little bit of time to work with the patient so they can find themselves in that content and really see that it applies to them before moving on. Because when we kind of jump into that movement, we want the patient to be fully confident with some of those ideas that we've talked about, so that they're ready to go.
And the model that we presented in our book was establish, communicate, act on it. It's different to this. It's more accelerated. And I think there are definitely different ways to approach it. What we've done here is formalize something that has had a huge amount of decision making, like in the process development, that we can then test. And we're really confident this process works. Even if you want to accelerate your patient, if you don't, you can just sit into that process and know that it works. And I think we'd recommend doing some reps on the process before freestyling too much, because it's had a lot of thought put into it, and it does work as it is. Yeah,
that makes a lot of sense. And all these treatment note templates that are in here, obviously you import them in, but then you adapt them, like you said, you adapt them as you want to, but maybe giving them a go first, and having some use of them before changing them, so you understand how they're working for you, could make sense.
Yeah.
So someone had a question, waiting until week 3 to establish whether a patient needs referring for investigation seems a long time for a patient that's in pain. Yeah, for sure. So I think that you'll get a really good gauge of that in week 0, and you can workshop through that. But it depends. So we'd triage people definitely, like if they've had a recent injury, but I guess for people that have, like most of the people have come with come from having a long-term chronic pain basis that we in the recovery coach trial that we built. But if there's any really like strong red flags that come up, you could definitely bolt that into session 0 as well. Yeah, that makes sense. So week 6 plus, is this? Would you open that template for each session after week 6, or how does that work?
Yeah, absolutely. That's a little bit what we talked about earlier, Joel, when we've sent a patient away with some predetermined kind of goals and plans, and then that's our come back and see what they've taken away and come up with actions moving forward. So that can be a rolling template, and again, that's one that'll, I think, be really adaptable moving forward.
Okay, that's excellent. Bear with me a sec. I'm just going to have a quick skim now some of the questions that I think that came up earlier that are maybe more applicable now that we've had a look through the templates. So we talked about how you assess the level of pain and the scale. You talked about a 0 to 10 scale for pain. I didn't notice those as I went through those templates. Do you have in here somewhere like a scale 0 to 10 or something?
We put that, there's an outcome measures section with...
Yeah, so I think it'll say their patient-specific functional scale, and then it will say add more as required. I think that's
which one should I have a look in? Which week number?
Week zero. Sorry.
Week 0. It's got a box called outcome measurement, and it's got the details for the patient-specific functional scale. And then under that, you just add what you're interested in. I guess for us, the patient-specific functional scale is such a cornerstone of how we work. It helps people to prove that they're making change, and also it's a really good goal-setting tool. And yeah, that has to be in there. And it's interesting in the clinic. Like our focus, definitely in research, we had to look into pain, but our focus on the clinic is more around capacity building in the initial stage than pain as well. But in the online course, we track pain and function and other things. But yeah, you can just add. Yeah.
So I have a question. Is this applicable to CRPS? I don't even know what CRPS stands for. I'm hoping you guys do.
Yeah. Complex regional pain syndrome. So yeah, definitely. We and I think that's why we've kind of gone slowly with. So like for us, it sometimes feels like we're going slowly with this content, but know that your prior is so different to your patient's prior as well, and what might seem really basic for you can often be a very different idea for your patient. So for CRPS, absolutely, this approach works, or is a good way to start. It'll just need, by the time someone's received a diagnosis of CRPS, they've probably got a whole lot of additional stuff that's worth addressing as well, and you just may do like different types of mastery experience and different types of exposure. But yeah, we've put lots of different types of patients, including CRPS, through this. Yeah.
So the types of exercises that you're looking to prescribe for patients or get them involved in, is it typically aerobic, resistance-based training? What sort of things are you working towards often?
Absolutely. I think that's probably a really great point, Joel, because our approach to movements may be a bit different to I guess, a classical physio approach. But we're really interested in movements that are like meaningful for the patient, and I think that's our number one, and that comes back to that patient-specific functional scale. So movements that they identify as being important, they're crucial to mastery experience, and then we'll build a program around that. So, it might be someone who's really, really interested in getting back, engaging with their grandkids and lifting them up again. And so that might lead us to like a gym-type exercise where we're lifting a barbell, but it's more about that bigger purpose for that particular patient. Anything about that?
Yeah, no. I think that's spot on.
There's a question which I assume that this approach is kind of covering, but people with long-established history of avoiding movement, they've got a lot of fear-based behaviours. Is there something specific or different for them, or is that what this approach is already designed for?
I think the latter. Yeah, I think this is really well designed for that person. And then it's just going to be that like clinical skill set of how to get them active, and and that's where I guess like metaphor and different things come in. So if it's like, and also that early education about really helping them understand why understanding pain matters. Because if they don't grasp that first lesson, then that's really the gateway into better movement. So I think for that patient, is making sure you're nailing all of those first steps. Because if you understand that pain's a protective feeling and not a measure of damage, and if you understand that injuries heal and that movement leads the body in even in fairly high levels, accommodating that and becoming stronger, then the patient will probably join those dots themselves and say, well, so what you're saying is I have to move more. And then we call them reflective mastery experiences, or getting them to look back on their past experiences and try and if experiences are facts and they join them in one particular way, it makes picture A, and we take those same facts, join them a different way and try and have a different picture with a different meaning. So I guess, like hopefully when they get that picture, they'll be arriving themselves at the idea that they want to start moving more.
That makes good sense. What about the sort of pain threshold for patients and the exercise you're getting to do? Is it always under their pain threshold? Are you having them move with pain? How does that relate?
Absolutely. So I think we frame this with a really important discussion with the patient, which around safe to move and tissue tolerance, and also about the utility of pain for them. So we'll often have a conversation where we, I guess, come to an agreement that pain's probably not serving a particularly great it's not serving them very well anymore, and it's become unhelpful. And that part of the process of retraining that may well mean doing things into pain. But we use, I guess, different measures for them to lean on. So lean on the capability of their tissues rather than what their pain system's giving them in terms of feedback. Lean on kind of what effort they're working at, those type of outcomes rather than purely just pain.
Makes sense.
Yeah.
What about the age of the patient? How does that impact? Like if you're, helping someone that's maybe elderly and really deep set fear of movement, for example, have you had personal experience with that? How do you approach it with someone like that?
Absolutely. I think we love this idea that our bodies and our brains are plastic throughout life. So it doesn't matter what age you are. Typically, your body's able to adapt to load and it's able to adapt to new information. So I think that's a really powerful concept. So there's no reason that age arbitrarily should be a barrier to engaging with this content.
Yep.
Absolutely.
And we've had some really young people as well. Like we've had lots of pediatric clients as well. There's a podcast on Tame the Beast, John Luca's story. He's a young lad that went through this really interesting story of pain, and I think young people respond really well to it as well. It's great to see how they fit it into their worldview. It's really interesting.
So people are wondering as well, what sort of role telehealth is going to play after COVID-19. But I think that what you mentioned earlier is really relevant, is that you were already doing, a significant amount of this via telehealth before. So, I guess we would assume that would continue at least. But probably, I keep getting the feeling that, post-COVID-19 looks a little different than pre, even, if and when we have it under control. And I personally would think that telehealth is going to play a bigger role in healthcare moving out of this.
Yeah, I think people really respond well to it. I think the more that everyone's developing a skill set in a video link, then it just it's so good, isn't it? It's like you can have a physio appointment at your lunch break even if you're not near it. But it really expands that space that you can market to, and you can develop a niche and workshop that. And I mean, rural health is a massive area of need with chronic pain treatment, and suddenly you can provide treatment all over the place. I think that it's a really positive time for delivering this stuff.
So I've got a question. I'm not clear what interventions you use. Is it only pain science education and exercise? Any psychological interventions or mindfulness?
Yeah, so we, I guess we're we're physiotherapists, and in terms of psych interventions, we don't go down, we don't deliver psych interventions, and we don't deliver too much, I don't deliver any mindfulness type work, but we do screen patients a lot for mental health, and we've got ways that we refer to psychologists if there's comorbid mental health challenges that we think are important to address. So we're interested in that, and we don't take that on ourselves as that challenge. Yeah.
Do you find that you get better adherence or compliance with doing exercises via your program that you do? And then maybe is there a difference between telehealth versus in person? Because I know I chatted with Karen Finnan some time ago, who's a completely online physio, and she was mentioning that the compliance to exercises she'd found was better with online sessions because people kind of know that you haven't touched them and haven't had any magic work done, so they feel more compelled to get their exercises done.
I think that's huge. I think you hit it right there, that for us, maybe our exercise compliance is really, really similar to what it is in the clinic, but that's maybe for the same reason you just mentioned there, that we don't do a lot of hands-on treatment. So for our patients, say if we've had a patient that's transitioned from in clinic to telehealth, their experience is probably fairly similar to what they had before. And so I think that, and the personalized approach we take with exercise and making sure it's particularly meaningful to the patient and it makes sense conceptually, it has purpose. I think those factors really get compliance quite high.
That makes a lot of sense. Like if you have a meaningful exercise that you actually want to be doing and want to get better at, you're more likely to do it than something you find, I guess, somewhat arbitrary just for the injury itself.
And we do a lot of activity scheduling as well. And I think that's just it's so important. So just literally workshopping their calendar for the week ahead and in very fine detail, placing these events at the start. And then by the end, we phase out of that and look for people to self activity schedule. Because otherwise, there's this interesting sort of thought where like self-management and all of this can actually they can still rely on you for self-management. So we try to really develop independence, and where by the end of it, I just think that's an interesting idea. Yeah.
So we've got a question which is probably something you've been asked before when you talked about this. So the question is, seems a lot of assessment, talking and education around pain management. What do you actually do to treat the patient in a clinical situation? So I assume that this is like a question you do get a bit, where if someone comes in and you're, predominantly a physiotherapy business, and like I said, you do very little hands-on treatment in that approach, you must have other practitioners or patients that are a bit surprised, or like, so where's the treatment?
It's so good, but we don't get that question. And this is just, it's so rare. And this is where we try to point to that data. But we are intensely partnered with our clients. I think the experience that they get when they come here is that they have entire focus on them, and we go to extreme lengths to enable our patients to recover, and there's just no space left for doubt. Like we're so partnered with them, we're so committed to their outcome. I think we've developed a skill set of being really good educators, and our patients generally, that just, it all makes sense and they understand it. But the fear here is real. Like lots of clinicians feel that way. And all I can say is that we see lots of clients, and that they don't expect the approach, and they get this approach, and they really respond well to it. It's just, you have to develop your own self-efficacy as a clinician to that, though.
I've got a question that's come up a couple of times about rebates. So you said that a lot of the patients you see are not private payers. They're like, this is probably Australia specific, but they're like work cover, private health insurance, Medicare, things like that, maybe on chronic disease management plans. Is that right?
Yeah, we don't do much Medicare. We see occasional Medicare clients, but most of ours is so Return to Work Safe put out a telehealth schedule, and we're just really open with the case managers that we work with around the way that we're treating, and we've had, it's been really positive. I think we've just found that a sensible approach like this, where you're just kind of like upskilling people and like enabling, like people respond really well to it if you take that approach.
Okay.
Yeah.
And I assume you just do billing under normal physio codes if you're a physiotherapist. There's not something specific or different that you use for this?
Yeah, true. Yeah, we just work under the normal fee schedules. Yeah.
Okay. I want to bring up as well, so I've showed those templates that you're going to make available to people. So I just want to talk through quickly how they actually get access to them. So let me share that again for everyone. So I'm on a website at the moment. We'll give you the link to it, but it's permissiontomove.com/Cliniko. You'll get a link to this. It takes you to a page to register. When you do click the registration, it'll just ask for your email and password, and you'll get logged in to a screen that looks like this one here. So it gives you access to the introduction part of the course that they have available and the product they have, as well as the ability to download all of these templates out of there. So you don't put in, there's no charge or anything like that. It's completely free. And once you're into there, if you do go to the welcome area, which is just what that's not going to be a good screen to see. I've got a proxy error on that screen. Let me just try one more time. Nope. So it'll look a little different to what I was just showing you there on yours. So you'll click on that welcome box there, and just on the right hand side you'll be able to download a zip file that has all of the templates that you can import straight into Cliniko, and as well as that you'll have some intro videos to watch. Perhaps Dave or Jack, who just describe what sort of videos they're going to find in there that are available for free.
Absolutely.
So it's an introductory module to our affiliate training course. So it's really just similar in some ways to the conversation we've had tonight about, I guess, trying to convince clinicians that they can do this, and sort of contextualizing recovery, and just a whole lot of different angles on getting a clinician to sort of level one where they're ready to kind of give this stuff a crack, plus a bit of content digging deeper. So it goes through the lesson format that we've got in our affiliate training. So for each one of the clinical note templates, in the affiliate course, we just built out training materials to teach you to do each step. And then that sits alongside the online course for patients as well. So that sort of fits together as that product with this coaching module plus the access to the digital product.
So a practitioner or a business signs up for this, they get access to the coaching, the training that talks all about using the templates that have been provided there, as well as other parts to working through this approach, and then they get access to all the video content, but also, like you said, the patient gets access to something that they log into and they work through the program outside of the sessions too.
Correct. Yeah. So we've set it up as a monthly subscription model for the course, to gain access, which is $50 a month, and then we sell the online course to patients for $195 Australian. But as an affiliate, then you just buy it from us for $20. So you sort of subscribe as a monthly fee and then use these licenses with your patients. So it's something like $3.50 a lesson, if you like. So I guess our goal is to really make this content available while still being able to produce resources like this. And then the clinical note templates are very similar. They've just got at the top, they refer back to the content that your patient will have covered. So there's some differences just because your patient may have already covered ideas in the online course. We've worked with really good quality animators, and yeah, we're just really happy with the quality of, I guess, the content across the board. It's looking really good.
Okay, so if people don't do the course, they use the templates that are provided for free because they're more standalone. But if they decide to sign up and use the product as well, then they'll have slightly different templates that aren't going to ask the patients the same questions and will refer to other things that the patient has done through their coursework.
Yeah, that's it.
Yeah.
Okay, and if they want to check up pricing, things like that, that's on permissiontomove.com. I assume that we can provide the links when we send stuff out afterwards as well.
Yeah.
Okay, that's great. So I don't think we have any other questions that we haven't covered off. We did well to get through all of them. Like I said to everyone watching at the moment, we're going to send through information to you. We'll email to everyone that's registered. We'll put a blog post up. We will have a Facebook post for all the different places you'll be able to find. So you'll get the links we discussed, references to the material we talked about. And also, we don't quite know yet our next webinar or broadcast like this, but we will let you know that as soon as we do as well. So thank you so much, Dave and Jack, both for joining for this broadcast, answering the questions and chatting with me. But really, the treatment notes as well is such a gift to people, and I appreciate you putting that together for them.
Thanks so much, Joel.
Thanks, Joel. Thanks a lot. Thanks for watching.
Thanks, guys.
And also, if anyone has any other comments or questions, you can still post them. We'll be monitoring the comment section for a little while. But thank you, everyone, for joining. We'll see you next time.